All right, so good afternoon, everyone. My name is Krishna Patel. I'm the Regional Oral Health Coordinator for Zufall Health Center, and I welcome you to today's webinar. Before we begin, there's a few housekeeping items. Participants will enter the session on mute to avoid any background noise. Today's webinar will be broken down into a 75-minute presentation by our guest speaker, followed by a 10-minute question and answer period from the chat, moderated by our Chief IT Officer, Brian Wang. So please feel free to chat in your questions during the presentation. Questions that are not addressed during the session will receive a response directly to the email account associated with that question. If time allows, we'll also take a few live questions at the end. You can raise your hand at that time to ask the question and you'll be unmuted. Today's session is being recorded, so keep an eye out for a link to our YouTube CE playlist in an email following the end of the webinar. The YouTube playlist will include a recording of this presentation and will be sent out within a week. CE credit is only available for those who attend the live stream and remain connected for at least 70 minutes. Viewing the recording only does not qualify for credit. A SurveyMonkey link will automatically pop up when you leave the session. If it does not pop up, you'll automatically receive an email with a link to the survey within 24 hours. Please make sure to complete the survey to receive your CE certificate if you are requesting dental credit. When you enter your information into SurveyMonkey, make sure to use the same email address as the email you used to register for this course. Make sure to enter your name as you want it to appear on the CE letter with complete words and capital letters where applicable. CE certificates will be sent out within 2 weeks. Zufall Health will be offering a series of CE webinars over the next few weeks, and you are invited to attend. Special thanks to Horizon Foundation of New Jersey for support for the Zufall webinar. We are pleased to be joined today by our guest speaker, Dr. David Bastachy. Dr. Bastachy is an oral and maxillofacial surgeon in private practice in Catonsville, Maryland since 1989. He has served as a clinical instructor at Johns Hopkins University School of Dental Medicine, Division of Maxillofacial Surgery since 2004. And I will now turn it over to Dr. Bastachy.
Okay. Hold on 1 second, I'm just getting to my share screen button here. We're almost there. Okay. I would like to welcome all of you to a program today entitled COVID-19 Overview. Just to give you a brief history on this program, I first gave this lecture back in early April of 2020. COVID-19 has had a major impact on every aspect of life here in the United States, and it's really had a major impact on healthcare and the way it's being delivered here in the United States. And our program today will go over how we're dealing with COVID-19 and how we're coping with it, and hopefully it will answer a lot of your questions that you may have in regards to this disease. Just as a disclaimer, all information in this presentation is obtained from non-copyrighted sources. I've not received any financial incentives from any of the companies that may be mentioned in this program. The sources of information that I used to develop this program came from a search engine called UpToDate. It's found in most medical libraries, most major medical institutions, the ADA, CDC, World Health Organization, and Johns Hopkins COVID-19 tracker. So these were all sources for information that we're using in today's program. This is a picture of what the virus looks like, and all of these red projectiles coming off the surface of the virus are really the key to understanding how we're going to be able to defeat this virus. As with all viruses, when we come to developing vaccines for these, we rely on having a surface antigen that we can tag and then attack with our own immune system. So what we're trying to do is program our immune system to make antibody to these antigens coming off the surface. And we'll talk a little bit about that as we go through the program today. Again, this is a repeat, just to give you an idea. I'm an instructor at Johns Hopkins 1 day a week, and the majority of time I'm in private practice in Catonsville, Maryland, which is a suburb of Baltimore. We're going to go back in time now to the mid-1350s. And there's a book that many of you probably are familiar with. It's written by an author by the name of Ken Follett. And it's all about cathedral building in an imaginary town in England called Kingsbridge. And as part of his story, he talks a lot about the bubonic plague and how it ravaged this town in England, but also how it ravaged the population all through Europe. We think that with the number of deaths and people that are ill with COVID-19 that, we're dealing with a major pandemic. A major pandemic was like the bubonic plague. It cut the world population by about 25%, from 475 million to 365 million over about a 4-year period. Now, we're just starting with COVID-19, and we don't know where it's going to end. And we hope that healthcare is much better in today's world than it was back in 1347. But only time will tell how we're going to deal with this pandemic. Just as COVID-19 started in the Far East, so did the bubonic plague. And it was along the Silk Road that the bubonic plague traveled. It was transmitted by fleas that were living on rats that were in the hulls of many of the ships, cargo ships, that were carrying cargo from East Asia, to all of Europe. Once the plague started, it didn't hit every city at the same time. As these ships disembarked in various port cities through Europe, the rats left the ships, the fleas left with them, and they started infecting people all through Europe. If you go and read the book that we were talking about here, one of the things that's mentioned is that the healthcare providers at the time in the Middle Ages were priests and nuns. The priests were the doctors, the nuns were the nurses, and they were caring for all these people with the bubonic plague. In science and medicine at that time, nobody knew what bacteria or viruses or fungus was. They just knew that these people were dying. And they had no idea what the route of transmission was. As it turned out, that the route of transmission, once people got infected, was through body fluids. So this is a bloodborne pathogen. The nuns in England that had started treating some of these patients communicated with the nuns in Italy that had been dealing with the bubonic plague for about a year or more before it came to England. And the nuns in Italy noticed that if they washed their hands and they used cloth masks, that the rate of transmission to the caregivers was far less than if you didn't use these universal precautions. So this was really the birth of universal precautions that we're now using today. And it worked in the Middle Ages, and it works, in the 21st century just as well. The nuns, unfortunately, tried passing this information on to the doctors, and the doctors were really resistant to taking any kind of suggestions from their nurse colleagues. The nurses' mortality rate, during the worst part of the bubonic plague, once they started using these universal precautions, was about 30%, whereas the mortality rate for the priests was about 95%. Now, the picture that you can see here to the right is a picture of what the priests started wearing after they finally caught on that 95% of them were dying. They started wearing these robes and masks and hats to try to prevent the spread of the disease to the doctors in hopes that we wouldn't wipe out the entire generation of doctors. If you notice, there's a beak on the mask, and the beak was meant to hold a cloth that was soaked in something that may be smelling like spices. When they were dealing with the bubonic plague, the rotting flesh from bubonic plague was putrid. And to get into a room with somebody with bubonic plague, you needed access to something that acted like an aerosol, almost like an air freshener. And that's what was inside of the mask itself. So now moving forward to the 21st century, we're going to talk a little bit about the epidemiology of COVID-19. So the distribution, the cause of the disease, risk factors, and specific health-related issues connected with COVID-19. Some of the clinical features, the actual way to diagnose people with COVID-19, how these people are being managed, and what we can do to prevent ourselves from coming down with COVID-19, and hopefully preventing the majority of the population from coming down with COVID-19. Now, coronaviruses have been around for probably centuries, and these occur in both animals and humans. And this particular strain was transmitted from bats, at least that's the belief, that it started off in bats and eventually ended up in a market in Wuhan, China, causing cross-transmission to humans. COVID-19 is in the same family as MERS and SARS. And so we already knew a lot about coronaviruses from the MERS and SARS epidemics. What we're looking at here is a slide of what the COVID-19 penetration was on April the 7th. And what I'm going to do is kind of chronicle what happened. I've given this presentation 4 times now, or at least researched it 4 times. And each time we're looking at the world map, the epicenters are changing. And if you look at April 7th, you can see that the major epicenters at this time were China, Italy, Spain, and the United States. And the number of cases in the United States on April 7th was about 337,000. So we had more than anywhere else in the world. And, you know, we like to be bigger and better than everyone else. So here we are. We have more cases than everyone else. The second map that we're looking at was taken about 4 weeks later. And what we're showing in the darkened areas where you see Russia, India, Niger, Algeria, Brazil, and Peru, these were becoming hotspots that things were starting to take off. This was in late April. Again, in late April, the main epicenters still were Western Europe. This is Turkey that is highlighted on the Mediterranean and the United States. And the areas that are sort of like the darkest red areas were the up-and-comers, or the ones that were sort of second in line as far as numbers of cases. On April 28th, remember we said back on April 7th, there were about 337,000 cases in the United States. By April 28th, that number had basically tripled, and the number of deaths had probably done the same thing. And again, we were leading the world in numbers of cases and numbers of deaths. And, you know, the questions still exist as to, you know, why this was happening. And a lot of it has to do with the mobility of our population, where somebody gets on a plane in the United States, and they've been flying all through the pandemic. And they travel from New York to California, and, you know, they expose everyone on the plane to what they have. And then they get to California and they have, you know, 150 or 200 contacts in California. And it really seeds this infection very rapidly. if you look at some of these other countries, like Italy, Spain, France, and even China, they basically quarantined parts of their country so that you could not come in or leave a particular geographic area. And this is one of the reasons why the numbers remained lower in these countries. And they reopened much slower than what we're doing right now. All right, so this is April 28th. Now we're up to May the 31st. And I started putting things together for this presentation at that time. And now these numbers come from Johns Hopkins, which they have a great site that you can go to. And it lists every country, every state, every county in the United States, you know, how many total cases there were. And you can see that from the end of April to the end of May, we essentially doubled the number of people that were confirmed to have COVID-19 worldwide, from about 3 million to 6 million. And the number of global deaths went from 150, 160,000 to 371,000. So things were not doubling as fast. When we were in April, from April 7th to April 28th, there were periods where the number of COVID-19 cases were doubling every 5 to 7 days. And now we're growing, at the end of May and into June, we're growing at a rate of about 2 to 3% a day. But the numbers are growing just because they're significantly bigger now. But it's a relative percentage. It's slowed down. So finally, this is a map looking at the hotspots as of May the 31st. And you can see the United States lights up bright red. Western Europe is still lighting up. But if you look at South America now, it's starting to turn red. And there are several countries in South America, Brazil being the #1 country, that now has the second most cases in the world. They have about 500,000 cases. This is as of May the 31st. And again, if you look at the number of deaths, we're still way ahead. We have 104,000, and Brazil is only at 30,000, 28,000. Here we are. This was actually from yesterday. I'm sorry. I put 6/9 on here, but it's from 6/8. And you can see that from 5/31 to 6/9, so it's about 10 days, we've increased the number of confirmed cases from about 6.1 million to 7 million. So we've increased about 16% in a 10-day window or 9-day window. And the number of deaths have gone from around 370,000 up to 403,000. So we've increased the number of deaths by about 10%. So things are slowing down, but they have not started the descent. We're still on a plateau. Some countries are on the decline. The United States is not one of them. Again, this is looking at 5/31 and where the hotspots are now. And you can see that Russia, Brazil, the United States are now the epicenters. And India is an up and rising member of this group. And there are other countries within South America that are rapidly gaining on the rest of the world. Argentina, Chile are all starting to show much larger signs of COVID-19 penetration. This is what they talk about with flattening the curve, or looking at the curve. And this is looking at the curve in multiple different countries. And you can see that in Italy and Spain, who were 2 or 3 weeks ahead of us, their curves are on the downside now. The United States is, I think, slowly on the downside, but we're more on a plateau. Russia is still climbing. Brazil is still climbing. India, I don't think anybody knows exactly what's going on in India. It's a huge continent, subcontinent all by itself. And the numbers that are being reported there, just like in Russia and China, are pretty sketchy. So I'm really not sure that those are accurate numbers. Again, looking at the curve, you can see this again was, I think from, this is back, it goes I think, to the end of April. But you can see that the worldwide curve, this is as of April 27th, the only countries that were on the down slope at that point were South Korea, China, Iran was starting to decline, Italy and Spain were on the decline. This is as of yesterday, and it's looking at every state in the United States and what the curves look like throughout the United States. And you know that the Northeast really got hit very hard. And going from, Massachusetts, Connecticut, New York, New Jersey, Maryland, these states really took it on the chin. And Maryland is still having issues. New York, you can see they're on the downside of the curve. Massachusetts is on the downside of the curve. New Jersey is on the downside of the curve. Our next slide here shows you, just blown up from that same slide, this is a picture of what the curve looks like in New Jersey versus in Maryland. In Maryland, we're reopening our state, and yet there are a lot of cases, and it's still increasing daily. We have these peaks and valleys, but we still have a significant issue here in Maryland. The thing that is more reassuring is even though the number of cases are increasing, the hospitalizations are going down. The number of really sick people are going down. The number of ICU beds being occupied are going down. And it's not just here in Maryland, but it's through the majority of the United States. And this slide was from early April. And this is showing, where the hot spots were. And the brighter the color, the hotter the area. So Turkey was hot here. The United States is still pretty hot. And you can see that Italy, Germany, Spain, China were all on the downside of their slopes. And this was in early April. Again, this is what the map looked like in early April here in the United States. So the epicenters here at that time were all of the Northeast, parts of Florida, New Orleans, parts of California, and the Seattle, Washington area, and areas around Chicago. So a lot of densely populated areas where, if people were not self-distancing the way they were supposed to, traveling on the metro, still going to work, spreading the disease, living in really cramped quarters. That's the reason why these areas lit up more than anywhere else. Once we got to April 28th, you can see the number of cases in Maryland, April 28th, were 19,500. Today, there are about 58,000 cases in Maryland. So the numbers continue to climb here. And, I'm watching them every day, and they're going up, 4, 5, 6% per day. So hopefully, we will eventually start on the downside of our curve. Again, the geographic distribution where they're looking at states that have greater than 40,000 cases. Think New York, it's a very populous state. New Jersey, far more populous than Maryland. And yet we have 50,000, 58,000 cases here in Maryland. New Jersey has maybe double that, but their population's probably 3 times what it is here in Maryland. So for whatever reason, we're having some major issues, in Baltimore City and the suburbs around Washington, D.C. That's accounted for a lot of the COVID-19 cases. And you can see between May 31st, we're looking at 1.7 million cases and 103,000 deaths. And here we are, that's as of yesterday, actually. And the number of deaths is about 110,000 now. And the number of confirmed cases is approaching 2 million. Here we are going back to April 28th, and you can see the states with the most cases back in April. New Jersey still has twice as many as Maryland, even on April 28th. They're probably, at least 50,000 more than that now, but they're 3 or 4 times the population now. Okay, again, when we're comparing April 7th, April 28th, and then we're going to look at June the 9th. The number of cases confirmed worldwide on April 7th was 1.4 million. The number of cases in the United States was about 400,000, and the number of deaths in the United States was about 12,300. The numbers at that point were increasing 17 to 20% a day. And the epicenters at that point were the US, Italy, Spain, and Iran. By April the 28th, we had more than doubled the number of COVID cases worldwide. In the United States, we had increased the number of cases 2.5-fold. The number of deaths was up by, let's see, from 12,300 to 58,000. And you see in the United States, there were only 6 million people tested out of a population of 335 million. That's as of April 28th. We were having problems with local governments being able to get adequate testing. The federal government had basically washed their hands of doing any testing at all. And this was all left up to the state and local governments to be able to do the testing. And by April 28th, the number of cases continued to rise at 3 to 4% per day. You can see where the new hotspots were: the US, Russia, India, Brazil, and Peru. As of yesterday, the number of worldwide confirmed cases is now up to 7 million. So in a short period of time, we've gone from 3.1 million, that's April the 28th, to here we are at more than doubling in about 5 weeks. The number of confirmed cases in the US is close to 2 million. The number of deaths is over 110,000. 25% of all deaths in the world or more, 26% come from the US. The one positive out of this is you can see that now we've tested about 20 million people here in the United States, and anybody that wants a test can get one. Unlike what the President of the United States said months ago, that anyone that wanted one could get one, now you really can. The number of positives is about 10%. And in reality, if we tested the entire population, that number would be a lot lower than 10%. That's something that 6 months to a year from now, we'll really be able to get a good handle on what those numbers really mean. As far as the geographic distribution, the first cases emerged from Wuhan, at least that they admitted to, back in December of 2019. And the epidemic peaked in Wuhan in late January, early February. So before things really got started here in the West, China was already on the downside of their curve. And by early March, there supposedly were no more new cases being reported in China. We relied on the Chinese scientists and physicians to be able to give the rest of the world a jump start on COVID-19, how we were going to treat these folks, based on their experience. They had a couple months of dealing with some very sick people in their ICUs, a lot of people that didn't make it to the hospital. And so we were able to learn a lot from the Chinese. They did share that information that helped the scientists and physicians all through the rest of the world be able to develop a strategy to be able to treat COVID-19. The initial route of transmission was from animals to humans, so from bats to humans. Person to person spread's now the main mode of transmission. And it occurs via a respiratory droplet transmission. So this is the aerosol that everybody's talking about. And this basically is the same way that influenza spreads. And one person can infect lots of people in a small area very quickly. This gives you an idea of the route of transmission using droplets from a sneeze. And there was a picture, I don't have it in my presentation, of somebody sitting on an airplane in the middle seat of a row, and they sneeze, and they can spread in any direction about 2 rows. So they can affect everyone in their row, the 2 rows in front of them, the 2 rows behind them, and the 2 rows on either side of the aisle. So you can get a lot of people from one sneeze. And the particle size is really small. And that's the reason why this can travel further. With Ebola, the particle size was very large. So if you were in the same room with somebody with Ebola, the likelihood of coming down with it, unless you came in touch with body fluids, was slim to nil. But with the COVID-19, it's not so much body fluids that we worry about, but the aerosol. And the aerosol is spread very easily. Again, transmission occurs when these droplets make contact with mucous membranes. So whether they make contact with your eyes, your nasal mucosa, your mouth, that's how the disease is spread. And the droplets do not travel more than 6 feet. So this is the reason why wearing a mask, if everyone is wearing a mask and somebody sneezes, the majority of the sneeze will not make it through the mask. If you're not wearing a mask and somebody else is not wearing a mask, that's the worst case scenario. And if you both are wearing masks, the likelihood of transmission is probably under 10%. So masks do help a lot. As far as the period when people are most actively shedding the virus, most people believe that this is the easiest way to detect the viral shedding is when the symptoms just begin, and that's when your viral RNA levels are the highest. That's when you should be tested, and that's when we're going to get most of the positive tests. Transmission to others occurs more likely in the early symptomatic stage than at the terminal or tail end of when you have the COVID-19. And the duration of viral shedding is variable depending on the severity of the illness. So if you have somebody that has minor symptoms that self-quarantines for 14 days, by the end of that 14-day period, they're no longer shedding virus. But if you had somebody that spent 3 weeks in the ICU, they're shedding virus for weeks. So they have to be isolated for a long time. And we'll talk a little bit about how each of these groups are managed. Again, patients with mild symptoms, which is no hypoxia, 90% of these people had negative viral RNA tests via the nasopharyngeal swab within 10 days after the onset of symptoms. For symptomatic patients, and those are people that develop respiratory problems that have many of the other issues, fever, the respiratory issues are the two main ones, but they can have renal issues and other organ shutdown as well. These people are shedding virus up to 37 days. The rate of transmission from a symptomatic patient, at least based on numbers that came out of China, was still low, 1 to 5%. As far as the immunity goes, and again, this is something that people have been struggling with, and the medical community has been struggling with. If you develop antibody, what does it really mean? How long does the immunity last? Once you're producing these antibodies, you're over this round of the infection, but does it mean that you can't be reinfected down the road? And we don't have enough data yet to be able to figure out that. Antibodies are induced in all individuals that become infected. So it's not like with hepatitis B where some people never develop the antibodies. Everyone that gets the disease gets the antibody. And again, we don't know the length of time that you have protective immunity, and that's the reason why these vaccines they're working on, we're hoping that it's lifetime immunity, but we don't know that right now. One of the treatments that has been developed is using plasma from COVID-19 patients. This is called convalescent plasma transfusions. And when you transfuse a newly infected COVID-19 patient with a unit of plasma that has antibody in it, the recovery is dramatic. I'll tell you a brief story. One of my best friends is a nurse practitioner at a hospital down in DC called the Washington Hospital Center. And he was on the vascular access team for dialysis patients. 4 of the people on their team all got infected from the same patient the same day, and all came down with symptoms the same day, which was 24 hours after being exposed. My friend, is a good example of the journey that people have to go through that once they've been infected. He self-quarantined for 8 days in an apartment in DC. And then he got to the point where he was having significant trouble breathing and was admitted to the hospital in a med-surg unit. Spent 2 days there and then was transferred to the ICU. His breathing continued to get worse. He ended up being intubated, was intubated for 3.5 weeks, nearly died, went into renal failure. And many of the different clinical trials of medications that we're going to talk about were used on my friend Jeff. And just to let you know, about 2 weeks ago, he was discharged from the ICU, extubated, and he's now in a rehab facility. He has to learn how to walk again. He had to learn how to eat again. He's still having some issues, but mentally he's 100% back. And, it's scary when you see somebody who's relatively healthy come down with this. One of the people on their team, which was their administrative assistant, died. She was in the ICU the same time that Jeff was. And 2 of the other people had milder cases of COVID-19. So, it brings it, it becomes reality. When you're reading numbers, it doesn't mean much unless you know somebody that's traveled down, this road. And, I've basically been in communication with my friend several times a week and being able to chronicle how he's done. So it's a good thing that there are good stories, not all bad stories out of this. The FDA has approved lots of different testing. When we first were in the process of trying to figure out whether we could see patients or not on an emergency basis, I wanted to be tested for antibody to see if I could feel a little bit more comfortable knowing that if I had the antibody, then I could feel more comfortable treating people. Unfortunately, most of the antibody tests that early on came out were not very accurate, 50% or less accuracy. And, I wouldn't believe the test results unless they were in the high 90s. So the test results are getting better. I think it is something that people now are willing to get tested for, especially after they've recovered from a bout of COVID-19. And it's something that we can use to be able to help individuals feel more comfortable treating COVID-19 patients. So a lot of the people in the ICUs, the ERs, and in the dental team that are treating, large swaths of the population are exposing themselves to people that potentially have asymptomatic cases of COVID-19. And if we knew that our IgM and IgG antibody levels were elevated, then we'd be the ideal group to be able to treat all these people and not worry about aerosol production. The story is still being written. As far as clinical features of COVID-19, the incubation period after being exposed is about 14 days. And again, most individuals become symptomatic 4 to 5 days after exposure. So again, with my friend Jeff, it was 1 day after exposure. But within 4 to 5 days, you'll know if you've had it. We divide the people that come down with COVID-19 into 3 groups. The biggest group, and this is good for all of us, are those people that have mild or no symptoms. So they either have a mild case of pneumonia, a low-grade fever, and no shortness of breath. And this comprises about 81% of all the cases. These people are able to self-quarantine at home for 14 days, get tested with nasal swabs for the COVID-19, and if they have 2 negative tests within 24 hours, they're able to go back out into the community. The people with severe disease are those people that their symptoms include shortness of breath, you know, O2 sats that are low, fever with a large part of lung involvement with pneumonia on imaging, and this comprises about 14% of the cases. And of these two, which now comprise 95% of all the cases, there were no deaths reported in either of these two groups. So 95% of the people that come down with COVID-19 don't have to worry about dying. It's the last group, and this is the group my friend Jeff was in, that went from severe, where he was in the hospital, to critical, where you have multi-organ dysfunction, shock, respiratory failure, something called ARDS, acute respiratory distress syndrome. This comprises about 5% of all the cases. Of this group, 50% or higher die. So he had a 50-50 chance or less of surviving his bout with COVID-19. So he was one of the lucky ones. Again, the overall fatality rate, if you look at everyone that's come down with COVID-19, is 2.3%. But the overall fatality rate of those critically ill was 50 to 60%. Again, most of the fatalities occurred in groups that had comorbidities, so advanced age, people 70 and up, people with cardiovascular disease, diabetes, hypertension, chronic renal disease, people that had chronic obesity with BMIs over 40, and immunocompromised patients. Now I want to just hold this thought for 1 second, and I want to show you something. I want you to look at the bottom of here. We're going to go back to, can you guys hear me? I'll just talk about this and then we'll go back to screen sharing, okay? At the bottom of this slide, there's a note that talks about people that are on various drugs to control autoimmune diseases like Crohn's disease, like some of the skin problems like psoriasis, people with rheumatoid arthritis. They're on these drugs called IL-6 inhibitors. And these drugs, like Xeljanz, Prograf, Cellcept, Remicade, Enbrel, Rituxan, Cosentyx, and Stelara, are all drugs that can suppress the immune system. Can you guys see my screen yet or not? Are you able to see my screen?
No, not yet.
Okay, let's go back to screen share. I'm gonna have to end this for 1 second and go back into Zoom. So hold on 1 sec. Can you resend me the link?
You should already have your Zoom session open, sir.
I should have it open. Okay.
Yeah, if we can see you on the video, your Zoom session is open.
Can you see me?
Yes.
Okay, so let's just, all right, but we can't get the screen share to work. All right, so you're gonna have to help me get to the screen share. I'm gonna minimize the presentation for a sec. Let me come back down to screen share. I'm almost there. Can you see my screen now?
That's perfect.
Okay. All right. So anyways, we talked about these different drugs that suppress the immune system. And if you watch the commercials that they have on TV, they all talk about, you have a greater chance of coming down with TB. You have a greater chance of coming down with different kinds of cancer. And when you're suppressing people's immune system, you also have a greater chance of coming down with COVID-19. So even though this is a drug, there's a drug in this family that's utilized for treating COVID-19, once it's occurring, this makes you more susceptible to the disease. These are some of the clinical features, and it shows you percentages of some of the symptoms that we see in people with mild, severe, and the critical forms of the disease. So you can see that one of these listed at the very bottom there is altered smell, which is anosmia, and altered taste, which is dysgeusia. We just had a patient that came into my office yesterday. She's a caregiver at a nursing home facility or assisted living facility is what it really is. And she said she came down with anosmia and dysgeusia, and those were her only symptoms. And when she told her nursing supervisor, you know, nobody at that point in time, this was back in early March, mid-March, they didn't really know or weren't aware that this is one of the symptoms. And this is sometimes the only symptom you're going to get. And the problem is that when you have these symptoms, you're shedding virus for a while. And so, you know, here she is working in an assisted living facility, and, you know, the residents there are all in their 80s. And they were at great risk for coming down with COVID-19. And so this is the sort of thing, it should send off a fire alarm when you come down with this particular symptom. You know, fevers now, that's the number one thing. It happens in 99% of patients. So in our office, in many of the hospitals I work out of, we take a temp check on every patient that comes in. Now, is that fair to do that on people that have dental abscesses or an endo-perio type abscess where you're going to have a fever? I can't say, well, no, we're not going to treat you. But, you know, it should at least be making us aware, ask some other questions. You know, you can see the other symptoms here: fatigue, dry cough, loss of appetite, muscle aches, shortness of breath, sputum production, and then the smell and taste problems. The spectrum is from mild to severe to critical. And again, patients in the mild group may progress over 7 to 8 days to the severe group, which happened to my friend. And then within another day or two, he was hoping he was going to get through the 14 days. He spent over 50 days in the hospital. And now he's been in the rehab facility for probably 2 weeks. So this has been a long journey for him. He developed the acute respiratory distress syndrome. And this is something that if you don't have enough ventilators, these people die. And unfortunately, there were people that developed this problem in nursing homes, and they would take them to the emergency room. The emergency rooms were just overwhelmed, and they sent the patients back to sure death. And that's exactly what happened to them. For people, again, with mild disease, you know, the recovery is in 2 weeks. Severe disease, it can take 3 to 6 weeks. And the critical, it can take months. You know, when we look at some of the ways that we follow these patients, you know, you would think with an infection, you'd expect to see an elevated white count. With some of these folks, you see just the opposite. You see a leukopenia and a lymphopenia. And the lymphocytes are responsible for making these antibodies to the virus. So this is all part of the immune response that we're hoping to see. Early on, the virus is winning. Some of the other things that are elevated, the lactate dehydrogenase indicates some form of tissue damage. Ferritin levels are elevated, so there's increased iron level. And the reason behind that is that you have decreased ability to exchange oxygen in the lungs. So you're trying to increase the oxygen carrying capacity in all of your red cells. So the ferritin levels go up. You'll see elevated aminotransferase levels. This is indicative of liver damage. The high D-dimer levels. And these are seen in people that have problems with disseminated intravascular coagulation. And some of these people develop things like PEs and DVTs. So, and this is what they started seeing in a lot of the COVID-19 patients. The more severely ill develop these coagulopathies. With imaging, initially they would take a chest X-ray or a chest CT. Once they took one, until the symptoms started to resolve, they didn't repeat this chest X-ray or chest CT. These things are going to look bad for probably weeks to months in the very critically ill. And so it takes time for these to resolve. It's not like a traditional pneumonia that you can kind of follow closely when it's resolving. This takes a long, long time to resolve. As far as, when we're evaluating and testing for people, we look for no new onset of fever, respiratory tract type symptoms. We try to figure out if the person has traveled anywhere where transmission levels are high. We had a patient that I was seeing at Hopkins who was living in New York and taking the train down to visit us. And this was in early April. And she calls me to tell me she's made a reservation to come down to see me. And I said, I'm sorry, but you're in an area where the transmission rates are really high. You need to stay where you are. And when things finally start to cool off, then you can come back and see us. Again, this was something where you can look at contacts that people have had, and when somebody comes down as being positive, this is the way to sort of self-quarantine many other people, and it's affecting huge swaths of the population in this country. As far as the priorities for testing, this slide is difficult to see. Initially, the people that were high priority were symptomatic caregivers, people in the hospital, patients and the healthcare workers. So if somebody thought that they had been exposed, they were going to get a test no matter what. And then it went from testing those folks to testing patients in long-term care facilities with symptoms. Then testing people 65 and older with symptoms. And then patient with underlying conditions with symptoms. And first responders like police, fire, and ambulance folks. And then critical infrastructure people. At this point, anyone that wants a test should be able to get one. So this slide is not as important anymore. Again, when we do the laboratory testing, it is important that they use these oral pharyngeal swabs. They're better and more accurate. If you're able to test somebody from their sputum, that's the best, because the virus really gets down into your lungs. But anywhere within the nasopharyngeal, oropharyngeal area, you can get a positive test for COVID-19. It's just that it's much more accurate if you get it from sputum. Now what we want to do is talk a little bit about how we manage patients depending on whether they're at home. These are the people with mild symptoms, whether they're severe and in the hospital, or whether they're critical. And we're not going to go into graphic detail on all these things, but just to give you an idea, if you happen to be having to self-quarantine, what you would need to do for yourself or to counsel other patients, what they would need to do. You have to monitor these patients pretty closely. And now with telemedicine, it is possible to zoom in or to remote in to your primary care physician and let them examine you visually from day to day. The most important things from a management standpoint is to be able to hydrate folks, to use antipyretics and analgesics. And the patient should wear a face mask to prevent transmission to caregivers. So if they're self-quarantining in a house where they have their own bedroom and their own bathroom, but the family member's coming in to check on them, that family member needs to wear a mask, wear eye protection, change their clothes after they come out of the positive COVID-19 patient's room, wash their clothes immediately afterwards. Wash their hands immediately afterwards. If you can wear gloves and masks, that's the best. These are the universal precautions that worked back in the 1350s. They still work today. You have to constantly surface disinfect. So, you can use Cabi wipes. You can use Clorox wipes, as long as it is effective against COVID-19. And the home quarantine continues until either one, the patient has IgG and IgM antibodies. If both test positive, then the patient's no longer considered infectious, or if they have 2 negative COVID-19 swabs within a 24-hour period. So in both of these cases, whether you don't have access to the antibody testing, no fever for 72 hours, improvement of respiratory symptoms, and 2 negative COVID-19 tests, then this person can go back out into the world. If there's no testing at all, then 7 days have passed since the symptoms first appeared, 72 hours without symptoms, and no fever, shortness of breath, or cough for 72 hours. Hospital care. This is for the severe but not critically ill patients. So these patients all come in and get oxygen support. They can get positive pressure oxygen, which is through the BiPAP. It's like CPAP. If the positive pressure is not effective and we're not able to keep their oxygen saturations in the 90s and they look like they're really wearing out, then they bought themselves a trip to the ICU to be intubated. If they remain in the hospital in a med-surg floor, they're going to get IV fluid hydration. We'll monitor their lab values. We'll monitor their renal function and their liver function, and we'll make sure that we address nutritional deficits. Some of the drugs that are available, and again, these are for the severe, not the critically ill patients. Steroids used to be used with lots of forms of pneumonia, and the physicians and scientists that were managing these patients decided that glucocorticoids like dexamethasone would not be indicated for treating COVID-19 pneumonia. They just didn't feel that it was effective. And the same held true for the non-steroidals. If anything, they felt that it had a negative impact on outcomes. And so they recommend if you have a fever that you use acetaminophen as your preferred antipyretic. These are the investigational drugs. And these are drugs that back in early April were considered more experimental. And as the numbers of people being treated has increased, we started to see that some of these drugs really are working pretty well. So the first drug we want to talk about is remdesivir. This is being used now on all the critically ill patients. And it targets the system the virus uses to replicate itself. So if you think of these are reverse transcriptase viruses, and so when they have to replicate, they have to reproduce a genetic strand of material. And the remdesivir replaces adenosine as one of those building blocks in the RNA, and it aborts virus's ability to replicate. This drug, according to Dr. Fauci, cuts the hospitalization time down by about 4 to 5 days on somebody with severe but not critical disease. So it cuts it down from, say, 14 days down to 10 days. So they feel that it really is effective. In the more severe cases, we've gone beyond virus replicating, and we'll explain to you how the next drug works. Not this guy, but this is President Trump's go-to drug, the hydroxychloroquine. And again, early on, people were advocating using hydroxychloroquine along with Zithromax to try to treat the disease early on. And this has been shown to have more side effects and be less effective than not doing anything at all. So this drug is not being advocated for anymore. This was something that came out from the Maryland Department of Health and Mental Hygiene, the State Board of Dental Examiners. And this was early on when, people were writing for drugs that they shouldn't have been writing for. So, in our Dental Practice Act here in the state of Maryland, it's specific that you cannot be writing for drugs that are not within the scope of care of what you provide. And the hydroxychloroquine is not a drug that the dental community should be writing for. Azithromycin, yes. Hydroxychloroquine, no. And if if you read at the very bottom, it says, it is outside the scope of practice for a dentist to prescribe these drugs. At the present time, dentists may only prescribe drugs that have a direct nexus to the practice of dentistry. So I don't think there were many people writing for this, but there were some that were trying to present this as, part of the thing that they could offer to their patients. Not a good idea. This next drug, tocilizumab, is an IL-6 pathway inhibitor. And it's really promising what this drug is able to do. And remember, we talked about all of those ones that treated psoriasis and rheumatoid arthritis and Crohn's disease. They were all IL-6 pathway inhibitors, but they're not meant to be given before you develop the disease, because it really impacts your immune system. But when you get to the critically ill portion of this disease pathway, you have something that's called is a cytokine release storm. And the cytokine release storm is the body's immune system releases all these cytokines as it is trying to destroy the virus. And once the release storm begins, even after the virus is no longer present, the damage from the release storm is what damages the lungs, kidneys, heart. This is what kills people. The virus itself is not what's killing people. It's the response of the immune system to trying to get rid of the virus. So this tocilizumab was used on my friend Jeff. He also got remdesivir, but the thing that really saved his life was the convalescent plasma. And he was one of 7 patients early on at the hospital center that was able to receive the convalescent plasma. They were not allowed to give this unless the patient tested antigen negative. So there were some people that had antibody that were still testing positive for the antigen. Eventually, they will be antigen negative, but it limited the number of donors available. And 1 unit of convalescent plasma from a donor could treat up to 2 people. So this was really, really effective, and we saw a massive turnaround for people once they received the convalescent plasma. For those of you that remember back in the days when, before people were getting hepatitis B immunizations, there is something called HBIG, and this is pooled plasma from people that have recovered from hepatitis B infections. And if you had an exposure, you could get some of this pooled plasma to be able to use to treat a hepatitis B exposure. That's what the COVID-19 convalescent plasma does, is that it really gives your immune system a boost. And it makes it so that your recovery isn't guaranteed, but it is significantly improved. This is one other drug. This is one we don't hear about much right now. This was back in early April. This was developed and being tested in both China and Japan. This is an RNA polymerase inhibitor. This is one of the drugs that is used for treating HIV. And HIV is also a reverse transcriptase RNA virus. So when we are able to inhibit the virus from replicating with the favipiravir or Avogen, then they think it is promising. These trials were taking place in China and Japan. There hasn't been much in the media in this country about it in the last 6 to 8 weeks. Okay, as far as prevention in the healthcare environment, this is something that we're all concerned about because we're seeing patients every day now, and we're asked to start doing elective surgical procedures. When this presentation was first put together, we were only seeing emergency surgical procedures. We still needed to be able to know, if we were at risk for seeing the patients that were coming into our practice. And in the hospital, you have to do the same thing. So we're screening all patients for clinical manifestations. And the number one thing that we always ask is, do you have a fever? And then, do you have a cough? Are you short of breath? chills. Have you been exposed to anybody that's had COVID-19? We then had to segregate our waiting rooms. So we had to have all patients wear surgical masks. We're still doing that today. We only allow one person into our waiting room at a time. Our waiting room can hold about 14 people. So it's one person, not even a family member is allowed in. When patients come to our waiting room, they have to call. They give us their cell phone number. We call them when it's time for their appointment. And back in mid-March, when the governor of Maryland told us that we had to postpone all elective surgical procedures, as of around March the 20th is when we stopped doing all elective surgical procedures, and we only did emergency surgical procedures from then until May the 7th. Some of the things that were recommended is that individuals with confirmed COVID-19 should always wear face masks. But at this point, we all wear face masks. The World Health Organization recommends standard contact droplet precautions. So if any of you work in a hospital setting, you'll think about people that were in these rooms that had negative airflow. We'd have to wear yellow gowns in. We'd have to mask and glove and wear eye protection before we went in. The majority of us, unless somebody had TB, were not fitted with N95 masks. Now, when we're working in the hospital, especially in the operating room and anywhere where there's aerosol generating procedures, we're either using N95 or KN95 masks. Inpatients in the hospital have to be placed in single occupancy rooms with a closed door, dedicated bathroom, preferably negative airflow, and the patient should be wearing a mask during transport anywhere in the hospital. These are what are considered aerosol producing procedures, and these came from the CDC. You look, they don't have anything on here about using a Cavitron, about using a high-speed handpiece, about using a surgical handpiece. The ADA has come in and said that these are also considered major aerosol generating procedures. We need to know that we have to be able to protect ourselves, but we cannot live in a bubble. And I'll show you some of the things we're doing in our office. It is something that, you have to be able to function and yet make sure that the patients are safe and the employees are safe. If we were working in the hospital, this is the way that you put on your PPE. You can see the first thing you do is put your gown on. The next thing you do is put your fit-tested mask on. Then you put a mask over the fit-tested mask. Then you put your goggles on. Then you put a face shield on. And the last thing you do is put your gloves on. When we take our PPE off, they're showing you that there are two sets of gloves. So you take the outer set off, the inner set are clean, and then you're able to take off your face shield, your goggles. You can then take the gown off inside out. And the final thing you take off is your N95 or KN95 mask, and then you wash your hands. There's a couple examples of ways to, take things off. But again, the main thing is if you have two sets of gloves, you want to take off, things that are dirty after you've taken off your dirty set of gloves. You still have a clean set on, and the final thing you take off before you take the second set of gloves off is your N95 or KN95 mask. And then you will put that in a bag and clean your hands, okay? This is a picture of my office, some of the modifications we've made in our office. To the left is my business front desk, and you can see that there's a frame in front of the front desk, and there are plexiglass shields in each one of those windows so that it makes for less likely transmission of anyone breathing on my front desk, since they are less than 6 feet apart. In the middle pane, you'll see that there's a window where there's a credit card machine, and we can transfer paper back and forth, and the patient can put their credit card into the credit card machine. But the ladies at my front desk feel relatively comfortable that they are not being unnecessarily exposed to anyone that comes into the office. They still wear gloves and masks, but they feel comfortable, and there's not been an issue since we have installed these things. In the waiting room, you can see how many seats there are in my waiting room. There used to be magazines and books and other things. All the magazines are gone. All the books are gone. There's no way to clean these. And I think the days of having magazines and books are probably coming to an end. You can see that we have lots of room in the waiting room. And right now we're only seating one person in there at a time. We may be able to social distance and have 2 or 3 people in there, but for the time being, it's going to be one person. On the left are the keyboards for our computers. These are made by a company called Seal Shield, and the same thing with the mouse. These can be sprayed. They can be wiped with Cavicide or Cavi wipes. The mouse itself is waterproof. You can spray it, you can wipe it. The mouse house, if you don't feel comfortable leaving it on your counter, you don't have to. But I do at this point, and we just wipe everything down. When I'm showing some things that we used traditionally for universal precautions on the right, that's a head from our x-ray machine. We are not covering these things with cellophane bags. There's a limit to what we're going to do. And at this point, we wipe everything down, we re-tape everything between every patient, we wipe the entire room down, we wipe the countertops down, we wipe the chair down. We cannot be any more safe than that. At least at this point, I don't think we can be. I don't have something to capture aerosol. I do have doors on every one of my operatories, and we can close the door when we're working so that we're not spreading aerosol throughout the entire office. But I don't have anything right now to vacuum the aerosol. Preventing exposure within the community. Hand wash changes into a mask, the likelihood of getting it on anyone else is pretty low. Avoid touching your face, your eyes, your nose, and your mouth. Clean and disinfect surfaces are frequently touched. Wear masks in high density areas. At this point, you can't go in and out of a store, in and out of an office building without having a mask on. Again, managing asymptomatic non-healthcare individuals with potential exposure. If you think you've been exposed, like say for instance, these people that are going to all of these protest marches, they're supposed to self-quarantine for 14 days after being in these large groups. They need to avoid contact with individuals at high risk, like elderly, people with respiratory issues, people with other comorbidities. They need to do twice daily temperature checks. If the patient becomes symptomatic, they need to contact their PCP. These are the proposed state and regional gating criteria. So we're only talking about phase 1 here. Most of the countries, at least in phase 2, some are in phase 3. And the reason why we are spending more time on the gating criteria for phase 1 is this is what really allowed us to start doing elective procedures here in the state of Maryland. We needed a 14-day of downward trajectory of documented cases. We need to be able to treat all patients in the crisis in the hospital regardless. But in our setting here in our offices, in order to be able to reopen, we needed this downward trajectory. The whole goal is to try to mitigate the risk of resurgence. I'm not convinced that we have done that, but it's far better than it was 2.5, 3 months ago. Each governor has the right to open the state, and then the various county executives will decide whether your county opens or not. But dental offices throughout the country at this point have reopened. Again, it is important for us to reopen the United States. People need to wash their hands, use soap and water, avoid touching your face, wearing masks. And schools are still closed, and many people are doing telework at this point. And follow the recommendations of your PCP. As far as employers go, and again, this is something that affects us. We want to make sure that our employees feel safe. We are doing the best that we can do with the PPE that is available to us. We are using KN95 masks. We are using, we're gowning between every patient. We cannot change our gown between every patient because we just don't have enough of them. I'll show you what people in our office are looking like in just a sec. We'll skip through a couple of these. And again, the main thing that you want to see is that elective surgeries have now resumed, and we're following the guidelines from the CDC to be able to practice safely. This is the interim toolkit that was from the ADA. This came out in late April. Many of the things that are in here still apply. I think that the real world, though, you have to realize that, like in the state of Maryland, the CDC has made recommendations or guidelines by which we should be practicing. Our state dental board decided to make those laws. Well, it's hard when you make a law that people have to do certain things, like changing their gowns between every patient, when those gowns are not available to be even able to be purchased in that kind of quantity. To have N95 masks when the only thing that's available to us right now are KN95 masks. We have what we feel is a safe environment for our employees. And, at this point, I think we're doing okay. This shows you the difference between an N95, KN95, and a traditional level 3 surgical mask. And if you read through the slides that were sent to you, you can go into more detail about the differences between these different kinds of masks. This is my contact information if you need to get in touch with me. My email address is listed. I promise that if you email me, I will get back to you. It may take a day or two. I've also listed my address here, my office phone number. So if you have problems and I don't respond, you can always call me on my office phone number. I thought I had pictures of my staff. I don't. I just will tell you that we use paper jackets, we use face shields, we use goggles, we use KN95 masks. We were trying to put a mask over the KN95 mask. It got to the point where people couldn't breathe. So we're wearing KN95s. We don't have a mask over those. We do have a face shield over them, and that's what we're doing. Does anybody, we can open this up for questions.
All right, thank you, Doctor. I'm going to go through some of the questions on the Q&A section. First question, if a symptomatic patient has signs of respiratory problems such as coughing and they come in for dental treatment, you mentioned that they can shed the virus for 8 to 37 days. How long should we wait before having the patient return for any dental treatment?
I think they should end up with a negative COVID test, the antigen test, or negative antibody testing. This is being done in all the hospitals now. So you can schedule an appointment and get tested in those places. And if somebody has symptoms and hasn't been tested, they should be. If it was an emergency type procedure, we are seeing people in the hospital if we need to, and they have the ability to use negative airflow rooms. And if they had to be treated in the operating room, we can do that. But I think that elective work on these patients should not be scheduled until they're asymptomatic. And even emergency type procedures, if they can be put on antibiotics, and once they test negative, then they can be treated.
Thank you. Next is more of a comment. I assume Humira as well?
Humira is another one that suppresses the immune system. So yes, that is one that, these people that are on Humira, it helps with rheumatoid arthritis. It helps with a lot of immune problems, but it suppresses the immune system. And so these people are more susceptible to different infectious diseases. And COVID-19 is one of those.
All right. How long do you let the operatory sit between patients?
What we are doing is about 15 minutes. I have 4 treatment rooms in my office. So, and there's only one provider. So it's easy for me to move, from room to room. And once the room is wiped down, and leave it that way for 15 minutes. Initially, the CDC had recommended 3 hours. How can you leave rooms down for 3 hours? Unless you have tons of treatment rooms in your office, you get to a point where you can't treat people. So I think that 15 to 20 minutes after things are wiped down, it's safe to go back in and treat patients.
All right, thank you. Lena had her hand raised. Lena, I have unmuted you. Do you have a question? Oh.
She's still muted.
It looks like it will not let me unmute her. Oh, Lena, if you do have a question, just put it in the Q&A. Another question came up. I work in an open clinic and we don't have negative pressure air. We have been working on emergency patients and still use aerosols. We have been using the proper PPEs.
Well, I will tell you that it's difficult to redesign an office. And I don't think that it's realistic to redesign an office. I think that there are these devices that you can now get their air purification systems that you can use to be able to, it's almost like a high-speed suction. Some of my friends are using those. They cost thousands of dollars. I think at a minimum, there should be barriers put between each dental chair. The people that have the most problems right now are the pediatric dental offices and the orthodontic offices, where they'll have 10 or 12 chairs in a room, and they've got all these patients in there. They may not be able to put people in every chair, and there are ways to build these plexiglass separators. You can do them relatively inexpensively. We had an OSHA presentation to my study club about 2 weeks ago, and the presenter talked about the fact that if you get these prefab separators, they can run $500, $600, $700 a piece. If you have someone build them for you, you can probably build them for the one that I have in my office for my business office was $275. She talked about using shower curtains. I don't think that's a great idea, but there has to be some way to be able to cordon off these treatment areas so that you're not spreading aerosol, when you're running a high-speed handpiece. These air purifiers that are available, I know that the dental supplier I deal with is Benco Dental. They have them. I'm sure Shine and Patterson also have them. So those are things that, if you're really concerned about aerosol generation, those are things that can be used. I know that for the hygiene community, it may mean that they have to hand scale instead of using an ultrasonic scaler. But if you're using a high-speed handpiece, when I use a surgical handpiece, there is aerosol being generated, and the best that we can do, wearing all the PPE, just like the person that asked the question is doing. And if you get blood splatter on your N95 or KN95, it needs to be clean. You can clean it with peroxide. If it gets to the point where it's soiled, then it needs to be thrown out. The KN95s we usually use them for 1 day and then dispose of them after that. As long as they're not soiled, we'll continue using them that whole day. But I think that it's a dilemma for us. We don't have negative airflow rooms. It's not inexpensive to create these things. So, high-speed suction is going to be important. And, using PPE, those are probably the best things you can do. The patient is not going to get anything from you. It's our fears we're getting something from them.
Okay. Thank you, Doctor. I think we have time for one more question before we hand this over to Krishna. If a patient is employed in a high-risk setting, such as a long-term care facility or hospital, and have no clinical signs of active infection, should these patients be scheduled at the end of the day?
I've seen these people in my office. I think that's probably a good way to schedule them. Many of these people, like the one woman that I was telling you about that worked in an assisted living facility, she was tested and came back, she has the antibody. So those people can be treated like anyone else. If they work in one of these facilities and they're asymptomatic and you're concerned, save them for the end of the day.
All right, thank you, Doctor.
Yes.
If you don't mind, if you could stop sharing your screen, we're going to pass this over to Krishna. For the questions that we have not reached, apologies. We will get to these questions in an email after the webinar. Thank you.
Okay, so thank you very much, Dr. Bastachy, for a very informative presentation. As a reminder, attendees will receive a SurveyMonkey link after exiting today's session. Please complete the survey to receive your CE certificate if you are seeking dental credit. CE certificates for today's webinar will be sent out within the next 2 weeks. Our next CE will be on HPV vaccine promotion strategies this Friday, June 12th at noon, and you're invited to join. For additional questions or information about today's presentation or future programs, please feel free to contact our Special Project Assistant, Yesenia Olvera at yolvera@zufallhealth.org. Thank you, be well, stay safe, and enjoy the rest of your day.
Okay. Thank you.
Thank you, Doctor.
You're
Thank
welcome.
you, Krishna.
Thank you.